Welcome to DocFlex's Global Diabetes Summit 2022, which is a 3-day clinical discourse organized from 12th to 14th November to discuss and tackle the largest and the most affecting disease of the world, discussing topics around access to global diabetes care and education. Today's session is focused on brain matters in diabetes. Several studies have demonstrated and proposed a brain-centric model for the development of diabetes, as the brain is actively involved in systemic glucose regulation. The brain detects levels of circulating nutrients and hormones and consequently organizes an outward response, maintaining whole body glucose homeostasis. Patients with type 1 or type 2 diabetes have been shown to have mild to moderate reductions in cognitive function. This association between diabetes and lower cognitive functions is primarily mediated by markers of neurodegeneration and cerebrovascular disease. With the ever-increasing incidence of diabetes worldwide, it has become crucial to understand the complex interplay between the central nervous system and peripheral insulin regulation. And to explain more on this, we have with us today Dr. Harish Joshi, Dr. Rahul Kulkarni, Dr. Leena Fadke, Dr. Aarti Behel, Dr. Sanjay Fadke. The session would be moderated by Dr. Vaishali Deshmukh. Dr. Vaishali Deshmukh is consultant and head at Dinanath Mangeshkar Hospital and Research Center and at Deshmukh Clinic and Research Center, Pune. She is also an assistant professor at Sassoon General Hospital and BJMC, Pune. She is also the founder and secretary of the NGO Sphere. She has numerous achievements to her credits, such as Proficient Women Award, Kranti Surya Pratishthan, Adarsh Mahila Puraskar, Jeevan Gaurav Puraskar. Dr. Deshmukh has interest in mind-body medicine, neurobehavioral endocrinology in women, and has numerous publications to her credit. So without any further ado, let's begin the session. Dr. Deshmukh, over to you.
Hello, everybody. Welcome to all of you for this interesting session on brain and diabetes. And we know that the brain is an important organ as far as diabetes is considered. However, it is less spoken of and less known and less taught about in diabetes as a field. So today we have an interesting session which will have brain as a part of diabetes occurrence. So brain as a causative organ for diabetes, which Dr. Harish Joshi from Hubli will take us through. Thereafter, we'll have Dr. Rahul Kulkarni, who is a neurologist from Pune, who will take us through the brain effects of diabetes, followed by a panel discussion on how mind is affected and how psychology is affected in diabetes. So we start with our first talk with Dr. Harish Joshi. I will try and introduce him first. Dr. Harish Joshi is an eminent endocrinologist from Hubli, Karnataka. He's in practice since past 20 years. He has several national and international peer-reviewed publications and more than 100 CMEs in India attended as speaker. He's faculty in more than 20 National Forum for Endocrinology and Diabetes, including orations to his credit. So we have Dr. Harish Joshi speaking on brain as a causative organ of diabetes. So over to you, Dr. Harish, for your presentation.
Hello, everyone. Now, we've been seeing a number of people with diabetes, be it within family, be it within the patients, be it in the world at large. Particularly in India, we have a huge number every day in the population becoming diabetics, and a huge number being lost to diabetic complications, right? So it's very, very important for us to understand the cause of the diabetes. Is it purely our lifestyle, or is it something to do with our mind also? That's what I would want to us to understand, that evidence also is there today to tell us that our mind itself can also be an organ which can create diabetes within us. So to understand the basic physiology, now we have a food with all the nutritional elements within it, and once they're digested into glucose, fatty acids, amino acids, and the associated minerals and vitamins, we absorb all of it, and that absorption into the circulation is then discharged through the tissue walls of the blood vessels, what we call endothelium, with the help of the insulin, which acts on its receptors at the cells within the tissues, promoting the absorption of this into the tissues and the cells, and thereby allowing them to survive and use this fuel. In the intermeal period, we have the liver, which provides us with the glucose, so that even if a person doesn't happen to eat for hours on end and starves, he still does not die. He can still do his activity. That's the liver glucose output allowing us to survive. Now, this liver glucose output is dependent upon the fatty acids, which comes through our body fat stores. So all this happens to keep our protein balance intact, so that the protein, which is the backbone of our body skeleton and the muscle and the tissues, is not broken down. And this maintenance of our body structure is through the interplay between insulin, which is the anabolic agent, and the counter-regulatory hormones, which allow our body tissues or the stores to provide nutrition when we are starving. How do these work? This fine mechanism is ingrained within our body, and for that matter, all living animals and humans. And this homeostasis is because of file measures which have inherited through our genetic mechanisms within each and every cell. Any perception of threat, either overt or covert, is immediately sensed by our limbic system, which is within our brain, and this feedback gives a feedback to the hypothalamus and the brainstem, what we call sympathetic activation system, creating an instant activity search of the subsequent pathways, bringing about an increase in the caloric provision to the muscle tissues, aiding us to have a flight away from the threat. This primordial survival response is equally active in all of us evolved humans. So though a primordial pathway, it is the most important pathway, and it stays as strong in all of us. The absence of the muscle activity in a thinking sedentary human does not in any way reduce the extent of surge of these counter-regulatory hormones, essentially keeping the insulin also in the overdrive to counterbalance the effect of this. So you have a high in the counter-regulatory hormones, you have high in the insulin also. So that is nothing but the insulin resistance, which is countered by the rise in the insulin. And when this excess insulin lasts for too long a time, it cannot be sustained. The beta cells which produce the insulin in the pancreas ultimately go into a fatigue, and then starts the problem of diabetes, as the insulin is no longer able to compensate the stress. Diabetes and stress are linked in several important ways. Stress can contribute to diabetes and can also be a consequence of diabetes. If any one of us is diabetic, or even if you is a diabetic, the first response is, why me? So that is the first stress. Then comes, okay, medications. Next stress. Then comes, I need I can't feel whether my sugar is high or low. So I need to have a problem when the stress itself can cause the diabetes, as research has now indicated. So be it depression, anxiety, all these, we see in a lot of people who have suffered a loss during these COVID years, and for that matter, even in otherwise, falling in the next few months or years, when somebody loses the near and dear one and are able to cope up with their loss, you find them to be diabetics. So a review article in 2010 reported that people who experience depression, anxiety, stress, or a combination of these were at high risk of developing diabetes. And in our evidence-based medicine, or what we call scientific medicine, we ought to have evidence before we say this is causing it. We can't just be biased because somebody said so. So now, even this era of evidence-based medicine, statistically proving things to be associated is what is important. And researchers from the University of Amsterdam in Netherlands a decade ago had suggested possible explanations for how these types of stress can give rise to diabetes. And these factors included lifestyle factors, hormonal factors, and effects on the immune system. So the explanations for how the stress affects diabetes are only theories, but we need to prove, and researchers have done their job and continue to do their job in trying to give us evidences as to how they work. Now, stress by itself can cause diabetes, one factor, but stress can also cause diabetes as a bypass through a bypass mechanism. What is that? You can call it a bypass mechanism or collateral mechanism. So the lifestyle factors can be affected by stress. We may have a poor quality diet. We don't pay attention to what we eat. We don't exercise because we have so many things to deal with. People may smoke and consume alcohol to beat the stress or the perception of stress. And our hormone values go for a toss with constant stress. Since 17th century itself, it was suggested that chronic stress can cause diabetes, and people who started pioneering work in giving us evidences and creating this discipline of allopathy or evidence-based medicine, that the foremost was Dr. Thomas Willis, a good famed physician, who noted that long-term of sorrow, sadness had caused diabetes in a lot of people. Then came Dr. Menninger in the early part of this century, who coined the term psychogenic diabetes. Then later, Dr. Slauson in 1963. A very small number of people were documented to have had a lot of antecedent significant negative emotional events of prolonged duration before they were diagnosed diabetes. A small number then, but this is how evidence-based medicine started. Now we have huge numbers in a lot of studies who have shown us data which indicates that yes, stress factors of long duration can cause diabetes. The word stress can be perceived in various ways. Currently, stress refers to the failure of the organism, the human, animal, to respond appropriately to emotional, psychological, or physical threats, which may be actual threats or imagined threats. And that causes a state of chronic alarm. Although the stress response of the body functions to maintain stability or allostasis, a long-term activation of the same mechanism can cause serious negative consequences for our body. In the early part of this 2000, we've had a lot of good data. Dr. Mui and who had analyzed the Hoon study, which involved 2,000 and more patients to evaluate the role of stress in causing diabetes. They found that persons who had experienced significant life events, negative, during the past 5 years, preceding 5 years, had a 1.6-fold increased risk of type 2 diabetes. The Hoon study also showed that significant life events were associated with the increase in the waist-hip ratio. And this increase in the waist-hip ratio, as we know today, is associated with higher risk of metabolic syndrome, diabetes mellitus type 2, as well as cardiovascular disease. Now, epidemiology-wise, we know the huge numbers that we have. Now, 2 years ago, the documented was nearly 422 million people worldwide. That's in Indian terms, 42 crores. And India accounts for a huge number of this. Nearly 2/3, 3/4 of the population of diabetes in the world are within the Southeast Asian countries, and India is slowly becoming the capital of diabetes. And South India, particular, huge number of people for various genetic reasons as well as acquired reasons. And it's not just the presence of diabetes, it's also the deaths because of diabetes, directly and indirectly, which happen because of diabetes. And most of the diabetes have type 2 diabetes. However, gestational diabetes, which we recognize now today in a lot of women, managed well, of course, with recognition, also has its antecedents as the same as for type 2 diabetes. And when we are addressing the risk factors for type 2 diabetes, we are also addressing the same for gestational diabetes and metabolic syndrome. So although type 1 diabetes has a different mechanism of pathogenesis, lifestyle measures and yoga can aid in a good control of blood sugar levels. A single maxim which we need to remember all the time: anything and everything that reduces the stress state, and more importantly, the perception of stress and the reaction to it, will prevent many of our lifestyle disorders. CNS is the central nervous system and the effects on the pathogens of diabetes. Okay. This is just to state, and evidence how evidence-based medicine works. In one of the studies, participants of a comprehensive 3-month residential program of meditation training program and yoga who were on low-fat lacto-vegetarian diet had a tremendous change, positive of course, in their body mass index, the cholesterol values, the fibrin, which is a clotting marker, and reduction in blood pressure, and the urinary excretion of metabolites of corticosteroid hormones was significantly reduced with the 3-month training program, which involved yoga and meditation. So this is how our evidence-based medicine gives us statistically significant results when done appropriately. The defects in the beta cell. What is beta cell? It's the islet cell, which is responsible for producing insulin within the pancreas, and the beta cell dysfunction in pre-diabetes and diabetes involves various components, primarily the acute insulin release, which is not only dependent upon what we call incretins from the small intestine, it's also dependent upon the vagal activity. And whenever the vagal activity is disturbed because of stress, you have a blunting of the acute phase insulin release, which can be corrected through proper lifestyle measures and even meditation and yoga. Particular postures have shown to give beneficial results with respect to the glycemic surge, reduction in the glycemic surge which happens after the meal when somebody is happy with themselves, pleased with themselves. And that happens through the neurological mechanism, through the autonomic nervous system. The qualitative and the quantitative disorder in insulin release are both corrected through lifestyle measures. And let me not get into too much of these details, but the important thing that we need to understand today is other than the insulin resistance in the muscle and the liver and the beta cell dysfunction, which is the insulin secreting defect, we have the ominous octet model of DeFronzo. DeFronzo, sir, is one of the pioneers in giving us a good insight into various aspects of causes of diabetes and the complications of diabetes. And he has done a huge amount of work and has shown that it's the brain, the adipose tissue, the gastrointestinal hormones, the renal system, as well as the alpha cells in the pancreas, all of them are contributing to the pathophysiology of type 2 diabetes. And even till 2016, we had a lot of material coming from DeFronzo Rai, and he's been doing this for more than 60 years. And the study that he did also emphasized the need for multiple drug combinations that we have today to correct the pathophysiological defects in diabetes. And it's not just reducing the A1Cs. So we are also trying to target the complication pathways also through pharmacological approaches. Now, if you look at yoga, the walking and the postures improve the gamma-aminobutyric acid levels, and the GABA induces a depolarization in the membranes of the beta cells, promoting insulin secretion. So without any use of drug, you have a simple walk, a yoga posture, which can improve our insulin release mechanisms. And not only that, the oxidative stress markers also reduced through yoga and meditation. The reduction in the sympathetic activity and increase in the parasympathetic activity, which happens with yoga, has a positive impact on the insulin release mechanisms and also in reducing the counter-regulatory hormone release, thereby reducing the insulin resistance at the cell level, and hence allowing our beta cells to live longer and our tissues to have a good amount of nutrition with less amount of insulin required to do their job. Now, other than this, we also need to understand there's something called as a lymphatic pathway of the brain, what we call lymphatics. Lymph channel is a secondary channel. Like we have the arteries which provide nutrition to the tissues, the veins which carry back the deoxygenated blood. We have also the lymph system within our tissues. In the brain, we call it as lymphatics. They carry away the toxin substances from the neurons. And the lymphatics open up pretty well when you sleep well. And there are some postures also which improve it, as we know today. So when the lymphatics don't work well, when the toxins are not removed well, then you have accumulation of these toxins, which ultimately cause Alzheimer's disease. And the same process also accounts for increase in the neurodegeneration stress and also contributes to diabetes indirectly. So if somebody sleeps well, adequately, then you have an excellent drainage through the lymphatics of these toxins. And most important is how we sleep. It's not disturbed sleep. You have continuous, refreshing sleep. that reduces the chances of neuronal damage. And as an associate, we are less likely to become diabetics, less likely to become obese, more likely to be alert and active through our elderly years. So methods which enhance the quality of sleep will improve the glymphatic functions, reduce dementia, reduce risk of diabetes. The role of Ratri Jagrana, which we have in our Indian women, men also many times, it's not a bad thing, but when you do it more often, too often rather, then you can end up with diseases also. So in the scientific parlance, in evidence-based medicine, the University of Chicago Medical Center showed that sleep deprivation or excessive sleep, anything below 5 hours or anything more than 9 hours, can contribute to glucose intolerance and to risk of type 2 diabetes. So the role of yoga and lifestyle measures suggested in yoga do play a role in the promoting our health, both physical and neuronal, and reducing the risk of metabolic syndrome, which is a pre-diabetic syndrome. And let's know that metabolic syndrome, which involves the dyslipidemia profile, hypertension, increase in the waist girth, with or without the presence of diabetes, is a significant risk for creating atherosclerotic end events, be it cardiovascular disease or cerebrovascular disease. So it's not just the diabetes per se. Even before diabetes, problems can start. That's what they call as metabolic syndrome. So lifestyle measures and yoga do reduce the chance of metabolic syndrome also. And a recent review in one of the studies in China also, with this huge population, has shown a 47% low risk of diabetic retinopathy in type 2 diabetics over 20 years when they had a good lifestyle intervention techniques along with pharmacotherapy. Now, what is this telling us? Stress response. When you have a proper lifestyle modification and a proper acceptance of the situation, not always regretting or repenting, and are into a meditation program, then you modify your stress response. And when you start doing activity in a proper manner, the acute response, you have increase in the parasympathetic activity, reduction in sympathetic activity, followed later a long-term lasting response wherein you have a reduced insulin resistance, improvement of the glucose values, then the lipid profile over the next few months showing a favorable trend, and of course a long-term benefit of being in a good mood and motivated. The chronic responses, you have reduced oxidative stress, less likelihood of progression of atherosclerosis, improvement in endothelial function. So less likely need for hospitalization for vascular problems. So possible pathways of benefit here at the brain level, through the yoga, at the liver level, at the renal systems, the adipose tissue, the skeletal muscle, the pancreas, gastrointestinal system. All of these can be improved through lifestyle measures and yoga. Yoga, there are a lot of postures in yoga, and particular postures are known to have particular benefits. That's also important. So it's a huge chapter which we can go through to proper people who are trained in it. You can also read good books to understand this mechanisms. And a lot of pharmaceutical approaches that we have today at all these, be it insulin secretion defect or the excess rise in the glucose following the meal, or be it increased breakdown of the adipose tissue to produce fatty acids and increase in the hepatic glucose output, increased reabsorption of glucose, all these can be corrected through our lifestyle measures itself. And a simple thing that was done was to give us evidence that, okay, what happens when you go for a walk? When you walk at speed of 5 kilometers per hour for 7.5 kilometers and do it for at least 3 to 4 months, many people with impaired glucose had reversed back to normal, right? But what's important here is nobody should be forced to do it. Should be motivated to do it. Do it with your mind being happy. Yes, you're doing it for your own sake. It's not just that somebody's asking me to do it. No, I'll do it for my sake. And that's where the mind plays a role. And again, what motivates us to it, how much to eat, it's our mind. So mind, through not just the mechanical effects of the stomach feeding, giving it back certain what you call feedback signals. It's also the chemical effects through the stomach, with ghrelin, leptin, adiponectin, all of them feed on the mind. But most important, our emotional state also has a role to play. Now, is the spiritual health important? when it comes to us as scientific doctors, we are trained to look at evidences only, not be biased through hearsay or emotional things. We have to have proper evidence-based approach to deal with things. But at the same time, spirituality, as we understand, is something wherein we're not talking about God particularly, monotheism, polytheism, or particularly this religion or that religion. No. Spirituality is being in the present, being mindful, being positive, accepting the world as it is, giving more than taking. And this kind of a feeling that of living for one another, right? That trust in the cosmic force without attaching a religious label to it does help us keep our mind fresh and, of course, make the surrounding a more healthy place, both for us and for our family as well as everybody around us. So when we are dealing with evidence-based medicine, we can't just say that, okay, being spiritual or something is not useful. It is useful. So let's not confuse yoga with a particular religion, be it Hindu. Yoga has no religion. Yoga and spirituality have no religion. They are related. You can put it as a metaphysical thing also, but though short of evidence, spirituality does help. Yoga, of course, we have a lot of evidence that it helps. Mind-body medicine now, it's not just for the patients that we deal with, even us as doctors, we are now getting evidences that when we are being trained, of course, during our time, long time ago, we didn't have these, but now the medical students today's day and age, are possibly more luckier because they have people who can train them to deal with things, become more empathetic. Look at life in all its colors. Look at patients as human beings who need help. Look at themselves as also possibly being people who could possibly fall ill, how to deal with it. And lifestyle measures which prevents burnout in doctors. So a lot of institutions in the US did a lot of study beginning 2010, 2012. And that model of teaching students to meditate, to do simple postural exercises, breathing techniques has helped people cope with the stress that a doctor faces in life. It's very difficult to describe a doctor's stress, but when we are, meditating, it may be for a very short time, be it morning or evening, right? And doing the simple breathing technique, just being mindful, it helps deal with a lot of stress, and that helps our patients also. So coming to the summary of this, what they did in nearly 15 medical universities in US, they demonstrated the effectiveness on reducing stress in medical students, enhancing the students' experience of medical education, helping the students look forward more confidently and hopefully to become good physicians, and they encouraged other medical schools to include the mind-body skills group in their curricula. And this has started now in India. Baby steps have begun, and I believe a lot of medical schools in India in the next 10 years would incorporate this mind-body healing techniques for the doctors and through them for the patients, right? So this is one of the slides just to how they went about, creating groups and going about steps in treating the people who are a part of the group. Who are those people? The doctors, the future doctors. So we can't go into details in this short time. So over the past 20 years, mind-body medicine has provided considerable evidence that psychological factors do play a substantiative role in the development and progression of coronary artery disease. And there is even enough evidence that this can be effective in the treatment of coronary artery disease, improving the results of standard cardiac rehabilitation, prolonging the quality and quantity of life for people, and even chronic diseases like arthritis, non-communicable diseases, particularly diabetes, all of them can improve through mind-body healing techniques. And evidence is there from multiple studies to show that even palliative cancer survivors, not cured, but able to go ahead with life, have been helped through a lot of mind-body mechanisms, techniques, many are there, right? And all of these have improved their tolerance of chemotherapeutic regimens also. And coming to immunity, we have seen during this COVID years how people have suffered, and people who had good immune responses, appropriate immune responses, survived through the COVID year pandemic, and will continue to survive, of course. But what is important, immunity has two things to understand for us. Immunity which is too much in overdrive is also harmful. Immunity which cannot drive itself to defend us is also harmful. So when you have a good, healthy mental and physical body, what happens? The immune response acts as much. You don't want to have an over-responsive. Over-responsive immunity is what we call autoimmunity. As happens in autoimmune reactions, in COVID, it happened. A lot of people's lungs got flooded with a lot of inflammatory fluid, which is a hyperdrive of the immune response. And people who survived had a good immunity. They did not damage the lungs or fibrose the lungs, primarily because the immunity was stable, not in overdrive, not in underdrive. And a lot of psychological and emotional factors have been studied in these healthy people and showed that that does play a role in regulating the immune response to a lot of infections. Now, coming to our imaging techniques, people who meditate for months together, and when their MRIs are studied, it is shown that a significant increase in left-sided anterior brain activity is seen to be associated with positive emotional outlook when they do the functional MRI. And meditation was associated also with an increase in the antibody titers to influenza vaccine, suggesting that there is a potential linkage between meditation being positive in our emotional outlook and localized brain responses and improvement in the immune function. So the same thing with the latest another imaging technique, what we call PET scan, right? And it has shown that a placebo response. Now, what is a placebo? Placebo is something wherein you give a tab or a capsule to a person, making them believe that it has medication, but has no medication. It is just a liquid. It could be just water or no active ingredient, but the person starts feeling better, primarily because the body responses are now in a positive mode. And that's what you call a placebo response. Okay. How does it work? The placebo response works through our psychoneuroimmune endocrine system. So when we believe that it will work, it works. So you find a lot of people who are unscientific, just giving a positive motivational talk, and the person comes out feeling good. That's because the positive impact it has on psychoneuroimmune endocrine system. But at the same time, we should not let a lot of charlatans get away with it, which is happening in our country, unfortunately. So coming to even wound healing also improves in somebody who has a good positive emotional state, and through the effect of the inflammatory pathways being driven in the positive direction through a psychoneuroimmune endocrine system. So to conclude, evidence from a lot of randomized control trials and in many cases systematic review of literature suggests that mechanisms do exist by which the brain and the central nervous system influence our immune endocrine autonomic functioning, which has impact on health. Multi-component mind-body interventions that include some combination of stress management, coping skills training, cognitive behavioral interventions, relaxation therapy may be appropriate adjunctive treatments for coronary artery disease, diabetes, and certain pain-related disorders such as arthritis. Multimodal mind-body approaches such as cognitive behavioral therapy, when combined with educational information component, can be used as effective adjuncts in the management of a variety of chronic conditions. And an array of techniques, imaging, hypnosis, relaxation techniques, when employed pre-surgically, can improve the recovery time and reduce the pain following surgical procedures. Neurochemical and anatomical basis may exist for some of the effects of mind-body approaches. Thanks for this patient hearing. What's important for us as doctors to understand is the austerity in thought is not needed. We need to think more. Austerity in prescription is definitely needed, with utmost essentials being written, and with a lot of empathy, no sympathy. Right? That will enhance our patient's experience and the quality and quality of life of each individual whom we treat. The word empathy and sympathy, we need to differentiate that. More empathy and less sympathy, world will be a better place. Thank you.
Thank you, Dr. Harish. It was an interesting and very eye-opening presentation, and you shed a light on an important topic which has rarely been spoken about, and thanks a lot for the same. We now have a second talk by Dr. Rahul Kulkarni, who will be speaking on effects of diabetes on brain. And Dr. Rahul Kulkarni is an eminent neurologist from Pune. He is attached to the Dinanath Mangeshkar Hospital, Pune, where he heads the neurology department. He is trained in neurology from TN Medical College, Mumbai. He is the secretary of Tropical Neurology Subsection, Indian Academy of Neurology. He is a member of many international and national neurological organizations. He is faculty in many international, national, and regional meetings. He has 12 publications and 2 book chapters to his credit. He is principal investigator in more than 25 multi-center trials in neurology. He is actively involved in training practitioners and students with special interest in CNS infections, neuroimmunology, and neurology education. So over to you, Dr. Rahul, for your talk on effect of diabetes on the brain.
Hello, everyone. I am Dr. Rahul Kulkarni, consultant neurologist from Dinanath Mangeshkar Hospital, Pune, and I'll be talking today on the topic of how diabetes would affect the central nervous system, particularly talking about the brain. So we heard about how the central nervous system of brain impacts diabetes. I'll be talking about how diabetes would impact the brain or the central nervous system in particular. We know that diabetes is a disease which is a multisystemic disorder. It can affect any part of the body. And currently we are talking about brain. And there are lots of newer things which are happening as far as brain involvement because of diabetes is concerned. And the theme that, or the topic that I'll be covering will be acute glycemic disorders which would affect the brain, the cerebrovascular events about which probably most of us would be knowing, the infections which are particularly seen in the central nervous system in diabetic patients, and my main focus will be about the cognitive disorders. And there's a lot of new data which is emerging about the cognitive disorders that we see in people who are suffering from diabetes. Talking about acute glycemic disorders, brain is an organ which completely or almost entirely depends on glucose for its energy source. So any acute alteration in the blood glucose levels can have wide range of neurological consequences. The symptoms can be in the form of depressed mental status, unconsciousness, altered mentation, focal neurological deficit, seizures. Most of these symptoms usually are reversible, but if the patient has got a very severe disorder or if the symptoms are being lasting for a long period, some of them can be reversible. As far as hyperglycemia is concerned, both diabetic ketoacidosis as well as hyperosmolar state, they have neurological consequences or manifestations, more so in elderly patients and more so with hyperosmolar state than with decay. And the features usually would include altered mentation, which can be in the form of drowsiness or confusion going up to a completely comatose state. Many of them may also get seizures. The seizures are usually in the form of epilepsy partialis continua. So in fact, in an elderly person who presents with new onset epilepsy partialis continua, we always suspect hyperglycemic injury as one of the most important differential diagnoses. These patients, and then of course they can get focal neurological signs, typically in the form of movement disorders like hemichorea or hemibalism. So giving just example of 2 of my patients who had hyperglycemic emergencies leading to a neurological disorder. She is getting the jerky movement. This was actually a lady who had a hemiballistic movement because of hyperosmolar state. And this is another patient who is getting jerky movement, but this time it was not this was not hemiballismus, but this was actually a epilepsy. So many things can happen as far as diabetics are concerned in hyperglycemia. And if you do imaging in acute setting, the CT scan or MRI can show unilateral hyperdense lesion on the CT scan or a similar unilateral hyperdense lesion on hyperintense lesion on MRI. There are many theories as what causes this. There is a theory of gemastocyte activation. There is a theory of microbleeds. Many things have been described, but this is a classic MRI or a CT scan that one would get in acute hyperglycemic, typically in hyperosmolar state brain injury. As far as hypoglycemia is concerned, hypoglycemia can also present with varied presentation, and everyone is aware of these. Initially, it starts with autonomic dysfunction, but later followed by neurological symptoms in the form of drowsiness. They can also have cognitive changes, behavioral issues. Some of them can get seizures, and rarely, especially elderly who have underlying cerebrovascular disease, they can present with focal neurological deficits, which can mimic stroke. So the counterpart of it, any patient who presents with acute illness which looks like stroke, it is our duty to always check the sugar in this patient to look for hypo as well as hyperglycemia. Okay, talking about cerebrovascular events, this is a well-known entity. We know that cerebrovascular events are very common in diabetics. The risk of cerebrovascular events increases by 6-fold in males and 13-fold in females who are suffering from diabetes. Usually associated hypertension increases the risk further. The disease is called as diabetic cerebrovascular disease. It is usually ischemic, but sometimes it can be hemorrhagic stroke or intracerebral hemorrhage as well. The mortality is higher than what one would get in a non-diabetic person. As far as its pathogenesis is concerned, it is a multifactorial pathogenesis. In a type 2 diabetic patient, it is hyperglycemia, the hyperviscosity, hyperosmolar state, hyperlipidemia, and hypoxemia. Everything leads to cytokine secretion that leads to endothelial damage, dysfunction, in turn which leads to activation of macrophages and internalization of the lipids. This leads to two things. Number one, it leads to formation of foam cells. Secondly, it also leads to proliferation of the smooth muscle cells, and eventually it leads to a cerebrovascular disease. The cerebrovascular disease in diabetics can be also caused because of multiple other cofactors. Many of these patients who are suffering from diabetes will also have increased homocysteine level. Some of them will also have increased levels of matrix metalloproteinase 9, and some of them will also have increased uric acid levels. All these three things are known to worsen or accelerate the atherosclerotic disease process. And we know that in diabetes, mitochondrial dysfunction is not an uncommon disease, which in turn can also lead to endothelial disorder. And the comorbidities which are often seen with diabetic patients like hypertension and dyslipidemia can also trigger the cerebrovascular events. The disorder can be, as I said, ischemic or vascular. It can be hemorrhagic. If it is ischemic, usually it can be a small vessel disease or a large vessel disease. A small vessel disease can present with a lacunar stroke or lacunar infarct, while the large vessel disease may present with a large artery territory infarct or a non-lacunar kind of stroke. As I said, hemorrhagic cerebrovascular disease leading to cerebral hemorrhage also is not uncommon in diabetic patients. And as far as vascular cognitive impairment, I'll be talking in the later part of my talk on this. As far as treatment or prevention or management of the cerebrovascular events in diabetics is concerned, the treatment would go like any other patient who has got cerebrovascular disease with tight diabetes control, antihypertensives with good BP control. For prevention, the drugs which are preferred by many of us are ACE inhibitors and ARBs. Idostatin in the form of atorvastatin, if the patient tolerates 80 milligram, is the one which is being used. If the patient has got a symptomatic disease in the carotid artery, they may require carotid revascularization in the form of stenting or surgery. And of course, antiplatelet agents, dual for initial short period, maybe a period of 3 weeks to 3 months, followed by single antiplatelet agents, or continue single antiplatelet in some patient from starting. But usually it is our policy to use dual followed by single antiplatelet agent. And there is no role of antiplatelet agents as far as primary prevention is concerned. They are the ones which are useful only for the secondary prevention of the disease. Talking about infections, infections also are common in diabetes, and two infections particularly are important as far as neurology is concerned. One of them is, of course, the one which starts from the ear, what is called as malignant otitis externa. Usually it is caused because of Pseudomonas, from where it can spread inside and it can lead to involvement of the bones around the brain, leading to skull-base osteomyelitis. The skull-base osteomyelitis can start from the malignant otitis externa. It is called as typical skull-base osteomyelitis. It can present with 7th nerve, 8th nerve, maybe 6th nerve, sometimes lower cranial nerve palsies, and headache, which is difficult to manage. Many of these patients do not have any ear discharge, so the diagnosis is difficult. We require high degree of suspicion for the diagnosis of this disease, and MRI or imaging may help us for diagnosis of this disease. There is another variant of skull-base osteomyelitis, which is called as central skull-base osteomyelitis, which starts exactly at the center. Typically, it starts around the bone, which is called as clivus, from where it spreads to other parts of the other bones of the skull base. And then it's again a difficult disease to manage as well as diagnose. Here, the organisms are usually non-Pseudomonas, and sometimes fungi or even mycobacterial infections can also lead to skull-base osteomyelitis, which is central type. Second infection, which is common in diabetics, we know is mucormycosis. And during the last epidemic of COVID, the last pandemic of COVID, we also had a big epidemic of rhinoorbital cerebral mucormycosis, especially in a country like India, where we had a havoc and we had seen lots of these patients. So invasive mycosis, more mucor than aspergillus, is also a common infection in diabetic patients. My main focus of today's talk is talking about the cognitive disorders that are seen in diabetics. Why am I going to talk on this? Because we know that dementia is not an uncommon disease. The burden of dementia is increasing exponentially. It is believed that 2.5% of elderly population suffered from dementia. That comes to around 1 case of dementia, which can be developing per 7 seconds in the world. And the estimated number would keep on increasing, almost doubling every 20 years. Estimated that there are 3 million people who suffer from dementia in India. The number can go up to, the number probably is around 10 million in 2020, and worldwide the number may be around 90 million. It can become 130 million by 2025. Financially, it is believed that by 2030, $2 trillion would be used per annum for taking care of these patients. So it's a very, very big burden as far as number of patients as well as the financial burden is concerned. There are very few drugs which are useful as far as treatment of dementia is concerned. Most of them have modest effect. None of them is shown to reverse the disease. And a pharmaceutical company or research industry has spent trillions of dollars for dementia research, which is all gone in waste. So now our main focus as far as dementia is concerned is presently identifying the risk factor and prevention rather than treating it. Where does diabetes fit in? Well, we know that the aging process starts as healthy aging, from where patient can get what is called as preclinical dementia. They can get what is called as mild cognitive impairment, and then it progresses to dementia. This is how the disease progresses. And at each stage, there are certain risk factors. Some of them are modifiable, some of them are non-modifiable. You can see that vascular risk factors has been there everywhere in this. So diabetes has been an important risk factor as far as dementias are concerned. Let's understand something about this. With the good improvement of diabetic care in last few years, fewer patients are developing the traditional diabetic complication. The number of nephropathies, retinopathies, neuropathies are going down because of good care of diabetes. So as the people of diabetes are living longer and living well with the disease, it is been seen that organs or structures which are not typically associated with diabetes complication are now getting affected. And two important organs are, one is brain and second one is bone. I'll be talking about the brain here. So brain structure and function is particularly concerned here because diabetes can impact the dementia as well as cognitive dysfunction, and that can dramatically reduce the quality of diabetic person. So type 2 diabetes has been associated with almost twice increased risk of dementia, and it is an important risk factor, a modifiable risk factor in this dementia patient. So if we treat it aggressively, we can reduce the burden of dementia globally as well as in India. As far as diabetes is concerned, the risk is also increased for both the types of dementias, the classically Alzheimer dementia, as well as the other dementia, which is called as vascular cognitive impairment, dementia which is associated with vascular disorders. This dementia was earlier called as multi-infarct dementia, or it had vascular dementia. Now all the terms are encompassed together, and they are now called as vascular cognitive impairment. So with diabetes, both the type of dementias are more common. In fact, diabetic patients get a unique kind of dementia, which is a combination of these two. And I'll be talking about this dementia. So there was an article about more than 12 years back in this journal, which said that this is the only final frontier which is not won by the diabetic care. We know that with diabetes treatment, you can take care of the other vascular risk factors, the cerebrovascular, the cardiac system, the kidney system, the retina, etc. But this is the only frontier which is not yet been won. We had little knowledge about this. Gradually, the knowledge is expanding. Last 10 years, we got good data about how this frontier is affected by diabetes. We know that the healthy brain, as the diabetes goes increasing, as far as duration is concerned, they start getting some kind of hippocampal injury, which is particularly seen with recurrent episodes of hyperglycemia. There is also reduction in the gray matter density in these patients. So the brain are atrophic to start with. on top of that, these patients get these vascular changes because of leading to changes in the white matter of these patients. Eventually, everything leads to atrophy, and then it leads to cognitive impairment. So this is as the diabetes increases over the duration chronologically, these are the various changes which can appear in these patients. And additional risk factors like hyperglycemia, recurrent episode of hypoglycemia, and the other vascular risk factors like hypertension, hyperlipidemia also are culprit in this. It is known, it's an interesting observation that diabetic patients, when they were seen in many studies, their baseline brain volume was always lower compared to a non-diabetic patient of that age. It would mean that the process of neurodegeneration would have started much early in these patients. And it seems that diabetic patients have less brain reserve. The concept of brain reserve, one has to understand that as the time grows, the brain volume keeps going down and down, and our reserve keeps going down. And if the reserve goes down at a particular below a particular threshold, then probably he or she would manifest with dementia. But diabetic patients always have a lower reserve, and they have a higher chance of getting disorder like dementia. It is also seen with diabetes. If the patients are followed up longitudinally, they get increased brain atrophy, and the cortical thickness is lesser over the time. So if you longitudinally follow these patients, these are the findings which can come up. Interestingly, it is also seen that the brain volume loss, everyone loses the brain as you grow. So the brain volume loss is about 2.54 ml per year in a non-diabetic patient, while in diabetic, the brain volume loss is almost double. It is 4.28 ml per year in diabetic patient. So if you do all the statistics, then it comes down to that for 10 years of diabetes, the brain looks almost 2 years older than a non-diabetic person. So if you are diabetic for 10 years, you're always 2 years older as far as brain is concerned. So you are diabetic for 10 years and you are 60 years, you are not 60 or 62. If you're diabetes since 20 years and you're 70, your brain is always 74. So that's what the brain is. If you are diabetic for a long period, your brain is going to be older. For every 10 years, it is going to be additional 2 years for the brain. Additional risk factors or the risk factors for the diabetes associated cognitive impairment are chronic hyperglycemia. So clearly uncontrolled diabetes is an important risk factor. Early onset, as I said, because the longer is the duration, the more is the brain atrophy in these patients. Recurrent episodes of severe hypoglycemia or recurrent injuries can lead to neuronal dysfunction because of oxidative stress as well as cytokine release. And comorbid hypertension, we know, is an important risk factor. So these are known things as far as diabetes-related cognitive impairment is concerned. This is all what available data is shown. Interestingly, it is shown that there is no direct relation between diabetes and the amyloid level, which is an important culprit as far as Alzheimer's disease is concerned. So in diabetic patient, they get they have this neuronal injury because of some other risk factors which are non-Alzheimer-like. So they have non-Alzheimer pathophysiology. They get what is called as age-related tauopathy, and of course additional mechanisms like neuroinflammation, changes in the glycation or glycation end products, insulin signaling. All these things can lead to worsening of the neuronal loss in a diabetic patient. So the diabetic patient get a degenerative disease, which is not like classical Alzheimer's. It's a little different kind of disorder. And it has been seen that if you do histopathology of these patients, there are lesser amyloid plaques and neurofibrillary tangles, which are known or which are most classic findings seen in Alzheimer patient. They're not very common in diabetic patient. They have more of vascular risk factors. So they will have multiple small strokes, or they can have microangiopathic cerebrovascular injury, or they can have multiple embolic strokes. So multiple vascular changes are seen in this patient. So diabetic patient have a dementia, which is like a vascular dementia, but there is also some additional Alzheimer-like changes in this patient. So it's a mixed kind of dementia, more towards vascular, little bit of additional findings, what are seen in Alzheimer's, and maybe some additional finding also. So this unique dementia by some people is called as diabetic dementia. So this is a different dementia compared to what we get with vascular dementia or with Alzheimer's dementia. It's a different dementia. It is called as diabetic dementia. And it is said that there are various risk factors or various pathophysiological factors in this. So oxidative brain injury, which is occurring because of leukoariosis, circulating inflammatory cytokines typically seen in obese patients, and advanced glycation end products which are seen with hyperglycemia. All these three things can lead to oxidative brain damage. There are inflammatory cytokines which have been produced because of this oxidative stress damage that can trigger increased level of amyloid precursor protein, and that leads to deposition of amyloid beta. So some Alzheimer-like changes can also occur because of this, but it is a reduced cerebral blood flow leading to brain hypoxia and reduced decreased brain function that is a culprit for the vascular changes. So both amyloid-like changes or Alzheimer-like changes as well as vascular-like changes can occur in diabetic patients. Diabetic patient can also get involvement of brain indirectly because of multiple other mechanisms. Some of them are, in diabetic patient, there is autonomic dysfunction. So they can get some arrhythmias, and that also can worsen the vascular risk factor or the vascular disorder. Repeated episode of hypoglycemia can lead to neuronal brain damage, as I said. Diabetic patients have increased chance of falling. So fall can also lead to recurrent episodes of traumatic brain injury, and that is known to produce what is called as chronic traumatic encephalopathy, again a type of dementia, which is a well-known entity. And they have additional hearing loss or maybe visual impairment because of so many other factors, which leads to sensory deprivation of these patients. That is known to worsen cognitive impairment, and they may have additional B12 deficiency or thyroid disorder. All these things can contribute together for the vascular dementia or for the type of dementia that the diabetic patient get, the so-called diabetic dementia. So all these things coming up together can lead to this phenomenon of diabetic dementia. Then there is an interesting role of insulin also in these patients. Insulin is known to influence cerebral biogenetics, bioenergetics. It enhances the synaptic viability. It leads to dendritic spine formation, increases turnover of the neurotransmitter. So insulin is important not just for sugar, it is also important for certain functions of the brain. It has got role in proteostasis, which leads to increased clearance of amyloid peptide phosphorylation. So it can clear all the bad amyloid from the brain. So reduction of the insulin can lead to increased level of amyloid in the brain. It also modulates vascular function through its effect on the vasoreactivity, lipid metabolism, and inflammation. So insulin dysregulation can lead to neurodegeneration by various mechanisms. So we need certain approaches with type of insulin, which is not just useful to control or correct the sugar, but also to restore the cerebral insulin function. So we need newer approaches to look at this also to increase or improve the cerebral insulin function. Again, an interesting hypothesis which has been published just last year in Lancet Neurology. So what it comes down to basically on a ground root level. Well, if you are seeing a patient who is suffering from diabetes, one always looks whether he has got an additional cardiac disorder, whether he has got a neuropathy, he has got a nephropathy, he has got a retinopathy. Start seeing whether these patients also get cognitive impairment. So screen these patients for cognitive impairment. The screening tools can be various batteries like mini mental still examination or Montreal battery. There are many batteries that we use. You can also always ask your neurology colleagues or friends as to which are the best batteries that can use. We also use a tool which is called as volumetric MRI of the brain, where we can actually measure the brain volume. We can measure various volumes of various parts of brain. So that's another test that we are using more often nowadays to assess these patients. And then, of course, because we know that dementia is becoming common in diabetic patients, we need to find out some preventive as well as treatment strategy in these patients. So this is a algorithm which has been suggested in a diabetic patient. Always assess whether they have these risk factors for cognitive impairment. Ask the patient whether they are getting any cognitive dysfunction. Ask whether any of these risk factors are there in this patient. If yes, then start doing their examination, not just doing their medical examination or history taking, but you should do certain tests. So probably all physicians or all the people who are caring for diabetes should know how to use this test. The test which is called as MOCA, which is Montreal Cognitive Assessment Test or Battery, which is a test which we use more often nowadays compared to mini mental status or MMSE examination. If it shows that there is some problem, then you can always refer the patient to your colleagues. And then if not, keep assessing these patients once every 2 yearly, 3 yearly. And if you think that the patient has got a cognitive impairment, then it is better that you involve your neurological or neuropsychology colleagues. Maybe this patient would require imaging, certain other tests. And then, of course, one should try and rule out other similar looking disorders like delirium or metabolic dysfunction or metabolic encephalopathy. So this is an approach which is one suggested as far as screening of diabetics for cognitive impairment is concerned. I think we have come to a level that when we are seeing a diabetic patient, not just check his ankle reflex or look at his fundus or do his urinary protein analysis. One should also ask them questions, maybe do a battery of their cognitive abilities. It's a disease which, as I said, has no major treatment. So we should try to look at prevention. It is a prevention which is most important. So one should try and enhance the reserve of this patient. As I said, the reserve is going down as far as diabetic patient is concerned. So we should increase the brain reserve by education. So education develops more synapses. He develops dendrites in the brain, and that improves his reserve as far as brain is concerned. So education is important, not just education of the school, going to school or college, but continue studying something. So our Indian style of retirement at the age of 60 should not be done. Beyond 60, keep using your brain, try to educate yourself, try to learn certain new things. You can form new dendrites and new brain tissue can be developed. Of course, exercise is an important thing which can help to enhance the reserve. And there is some minutes per brain. If you sleep well at night, it removes certain bad things from your brain through a system which is called a lymphatic system that helps us to enhance our brain reserve. This is a different topic. And then, of course, prevention of the cerebrovascular risk factor is an important thing because vascular risk factor prevention by good control of hypertension and lipids is an important thing. Whether there is a primary role of antiplatelet that is being not known. There is some data to suggest that metformin may be a drug which is helpful to reduce the chance of dementia and diabetics, but of course we need more and more data. Maybe some more specific drugs to be used in these kind of patients. So our awareness about this disease of cognitive reserve or cognitive impairment in diabetes is improving. Our knowledge about this disease is improving. Hopefully we may come up with some therapeutic strategy in future which can help us to prevent this deadly disease. Thank you. I think I'll stop here. Thank you very much.
So thank you, Dr. Rahul, for that extensive discussion on how brain is affected by diabetes. And we know that this is an important topic as far as neurology and diabetology is considered. Now we move on to our next session on a panel, an interesting panel on how psychology is affected in diabetes. And for this, we have three eminent faculty members. We have Dr. Sanjay Phadke sir. He's eminent neuropsychiatrist from Pune. He's the alumnus of NIMHANS and Neuroscience Fellow from Germany. He's senior consultant neuropsychiatrist at Jahangir Hospital, Pune, Dinanath Mangeshkar Hospital and Research Center, Pune. He's the chair of Indian Psychiatrist Society's Task Force on Mind-Body Medicine. He's the chair of Center of Behavioral Medicine, initiated Indo-German collaboration on neuroscience of yoga. He's formerly associate professor and co-investigator at the ICMR Center for Advanced Research. His research career includes principal investigator for more than 50 international clinical research projects, and he has been an official presenter of Government of India's first international conference on yoga at New York 2018 and Government of India's Vaibhav Summit in 2020. I am also proud to mention that he's been my mentor, and we are working together in mind-body health, and I'm so glad he's here today. So welcome to you, Dr. Phadke sir. Then we have Dr. Leena Phadke madam. She is MD in physiology, and she is presently the professor and chair of Central Research Lab and coordinator of Incubation and Innovation Center of SKNMC and Government Hospital, Pune. She is trained specifically into cardiac autonomic function test, heart rate variability assessment, and certified in mind-body medicine with a scope certification of UK in obesity. She is founder, secretary of Research Society of SKNMC Pune. She is principal investigator in many multidisciplinary research projects, especially predictive medicine, HRV card testing for screening of CAD in type 2 diabetes, HRV pattern recognition using machine learning approach in diabetes for screening of diabetes complication, autonomic adaptability and learning in yoga and exercise. More than 30 national and international presentations and publications to her credit. She's a faculty and speaker at various national and international platforms at the Indian Science Congress, Nimans Yoga Forum Munich, Germany, and Synapse Pune. So welcome to you, Dr. Phadke Madam. Our third panelist is Dr. Aarti Bahel. She is a consultant psychiatrist from Mysore at the Apollo BGS Hospital since 2004. She's MBBS in 1998 and she's done a MD Psychiatry in 2002 in practice for nearly 20 years. And she's also done her PGD MLE from Bangalore. She's previously worked as assistant professor in Department of Psychiatry at KMC Manipal for 2 years. And she has presented about 6 papers in national and international conferences, authored chapters in 2 books with special interest in mental disorders in women, OCD, medical legal aspects of psychiatry. So welcome to you, Dr. Aarti.
Hello.
Yeah. So I will stop sharing my screen so that we can have a panel discussion revealed. So welcome all of you, and it's my pleasure to have all of you on this forum to discuss psychology of diabetes. So let me start with Dr. Leena Phadke. Madam, you are a clinical physiologist. So let us know about what is the link between mind and brain. So can you just elaborate on that?
Yeah. Thank you, Dr. Vaishali and Dr. Axis for inviting me over here as a panelist. It's a kind of very philosophical question, but that what is the difference between brain and mind? But I will try to explain it scientifically as much as possible. Now, traditionally in modern medicine, we have always been taught as what we see is in anatomy and what we cannot see. So that is what is intangible is in physiology. So something which is tangible, you can touch, is always been taught in anatomy, and intangible is in physiology. So I think if we see brain and mind in this context, so you will know that all the organs, they have a specific defined structure which you can see. So what we call brain as, it's the structure that we are able to see. And the cells which are there in the brain or in any organ for that matter, which a lot of processes that are happening at very nano level. Maybe these processes are electrical or chemical, that the brain, what call it as, has a structure. So what we see as what we call brain is as a structure. And all the cellular processes that are taking place in different networks which are present in the brain, which we cannot see, are what you can call it as a mind. So the structure we see is a brain, and the functions that are happening, that are taking place at the cellular level in brain is what is the mind, is what you can call it as mind. So basically, both of them are inseparable. Brain and mind, yeah, I can say that it's two sides of the same coin. So this is how the structure and function, they both are linked together, and almost they are inseparable. One is
the anatomy and the other is the physiology. That is what you're trying to say.
Yes.
So I think that's a very nice way of putting it. So, Dr. Aarti, what are the mental health disorders that you come across in diabetic patients? Do you see mind health being affected in diabetes patients?
Definitely it is. The most common ones that we come across are anxiety and depression. And that's actually a thing that we see across all chronic illnesses when a person is faced with any chronic, long-lasting illness. Another one important factor with diabetics is substance abuse, which many of the clinicians actually fail to ask or miss out on. And actually it impacts your diabetes management, the outcome, repeated hospitalizations. Obviously the morbidity and mortality increases with substance use. So that's another thing that clinicians should be aware of. The fourth illness that is commonly associated with diabetes is schizophrenia. That could be also because of the medicines that we use in schizophrenia, or the lifestyle implementations that a person cannot do when he's a schizophrenic. That leads on to diabetes. Another off late, the kind of disorders that we are seeing is in these young adults, especially type 1 girls, having eating disorders like bulimia and anorexia. So these are the common things that we come across these days in diabetes.
Okay, so I think there's a vast array of psychiatric problems coming in diabetes, and most often they are masked or unmasked by them getting into the clinic with their sugar levels. So I think that's
absolutely
one of the markers. So, sir, I wanted to ask you: can mental illness itself be a cause for diabetes? Can it really, the psychological illnesses per se, produce diabetes?
Yeah, I think that's a great question, because it relates the relationship between the disorders of mind and diabetes. It actually, you can say, goes to two levels. One of the levels is shared genetics. So there are genes which are responsible for the metabolic disorder spectrum, which includes diabetes, and which are also involved in genesis of the common psychiatric disorders, as we know. So at one level, you can say it's like a deep connection, shared genetics between the two set of disorders. And then a second aspect, which is also highly prevalent, the psychological stress. Psychological stress itself is also, as we know, is a driver for this whole set of metabolic disorders and diabetes. So we have to understand, therefore, that this relationship is pretty deep, because the genetic relationship and stress, which is very highly prevalent. So in a model, wherein a vulnerable individual, the stress itself is also adding to the part of the pathology. So they do share, and there is also a third aspect to this whole connection between the mind and diabetes. We all know that behavioral aspect or the lifestyle management aspect is of great significance, as far as the management of diabetes is concerned. And invariably that involves some kind of a habit change, adherence to a healthier type of a lifestyle. And we all know that behavior change is not such a easy aspect. So I would say that in addition actually to the pathology that they share, this third aspect of being very mindful of the behavioral change, which is very critical and a key to successful management of diabetes. So that is how these three aspects, link the two problems together.
So it's not a very simple link. It's an intricate, complex link that gets these two together. Okay, so madam, I had a question for you. You deal with a lot of autonomic dysfunction issues. So what is the role of autonomic nervous system in mind health, and how does it play a role?
So Dr. Vaishali, if you see the functioning of mind, then most of the time we know that it has all the brain networks, they have a lot of spontaneous activity. And at the same time, they function in a very automatic way. They get there are a lot of inputs from various other networks in the brain, as well as feedbacks it gets from the periphery. So all in this way, means input from periphery, inputs from different networks, other networks in the brain, all of them, they actually have an effect on the functioning of mind. At the same time, a lot of inputs, visceral inputs that come from the autonomic nervous system. So the most important I can tell is the vagal afferent. So vagal afferent, which actually constitute about 80% of your vagal nerve. Lot of inputs from this vagal afferent, it goes to different areas of these brain networks. So mainly it goes to the monoaminergic system of your brainstem. It also goes to the hippocampal. It also goes to amygdala. And most importantly, it also has an effect directly on the VMPFC, that is ventromedial prefrontal cortex, which is a part of a default network. So a lot of influences, the inputs from the vagus itself has a lot of influence on the activity of mind. And so if you see from the mind-body interventions, then I can say that on one side, the mind is having a lot of feedback mechanism on which it works. And secondly, the executive network, which also have influence on different functioning of mind, plays a dual kind of control. You can say dual kind of regulation of mind itself. On one side, you are having feedback control, which acts almost automatic way. And on the other side, you have a executive control over your mind function itself. And the autonomy is the third, via vagal upfront, influences lot of functioning in them. So that's how autonomic plays an important role by affecting different parts of these brain networks.
So in short,
Yes.
you are telling us that autonomic nervous system is an integration of all the inputs from different parts of the body. And this
Yes,
is how
yes.
the mind is regulated by the autonomic
Yes.
nervous system. Yeah.
Yes.
So thank you, ma'am,
Yeah.
for that answer. What is the link between depression and diabetes, and you see that suicidal tendencies, negativity, a lot of these things are associated with diabetes. So is it a real link, and how is it affecting diabetes?
There's a definite established link between diabetes and depression. People who have diabetes, they have 2 to 3 times higher prevalence of depression compared to the general population. So that's a known fact when we come to the epidemiological studies. Now, there could be various factors why, depression and diabetes coexist. One is that, they could just independently exist. A person who's having diabetes could just land up with depression just like that. The other way of looking at it is when a person who has diabetes, there are certain factors in this person which could lead on to depression. Say biological factors like increased cortisol levels, inflammatory cytokines that could be leading on to depression. On the other hand, we also know there's a lot of lifestyle changes that a diabetic needs to do. I mean, it's not easy living a life of a diabetic, a lot of changes that a person has to bring about in the daily lifestyle. And that itself brings about a lot of psychosocial stress on the patient. There's a lot of stigma attached to, being a diabetic. That itself, causes a lot of stress on the patient, which can again, lead on to depression. When a person who is depressed, this person obviously is not motivated enough to work out, to live a healthy lifestyle. Such a patient, will probably be more predisposed to developing diabetes. And if a diabetic patient develops depression, that person may not want to, keep going, getting himself tested regularly. That motivation itself will not be there. The enthusiasm to go and see a doctor, to maintain a healthy lifestyle. Obviously, all this, brings about a decrease in the quality of life, increased number of hospitalization, increased cost of care, increased overall morbidity and mortality in patients who have diabetes and depression. So, these are just simple questions like, asking an open-ended question like, how are you feeling emotionally? The PHQ-2 that, we keep insisting on that, every clinician should know about. Just asking a basic question as in, are you feeling depressed? Are you feeling down? Are you feeling hopeless? Or, do you think you feel interested or you feel enthusiastic enough in doing things these days? Just 2 simple questions will bring about an answer. And these patients are very, very close to you. You've been following them up for years together. They'll happily open out to you. So they'll happily tell you, what is going on inside their minds and probably, even come out with the fact that, yes, doctor, I'm feeling depressed. Check on always, things like death wish and suicidal ideation. Because, when you come to know that a patient is suicidal, that's the time when you don't wait for therapy or any other non-medical intervention. So, better start the patient on antidepressants or refer that patient over for a psychiatric review or an opinion. That is how, we need to identify and treat patients in a diabetic clinic.
I think very important points that you brought about, that one needs to ask open-ended questions, because most of the patients do not come up front with these questions and even the answers. And second important that you highlighted, the 2 simple questions. Are you really feeling depressed? Do you feel like dying? Do you feel enthusiastic? All these three simple open-ended questions will give you good answers. In fact, today I saw one patient who has been uncontrolled and very brittle for years together. And today I just happened to ask her that, do you have any problem in the family? And she started crying. So I just realized that it was very silly on my part that I did not ask this for so many years that she's been coming to me. So I think a very important point that you've highlighted. So, sir, coming back to you, when we talk about psychiatric medicines, so there are two aspects to this. One is, do psychiatric medicines cause diabetes? And is there a role of psychiatric medicines in improving diabetes? So both ways I'm asking you. So what is your view on it?
Absolutely. So the newer antipsychotics or the so-called second generation antipsychotics, they have been notorious in terms of the weight gain, obesity, and as well as raising the sugars. So second generation antipsychotics, when they initially came in, there was a lot of enthusiasm, because as we all know that the first generation antipsychotics, they produced the drug-induced Parkinsonism or extrapyramidal syndrome, and patients look, aesthetically not so great, because people develop Parkinsonism. And when the second generation antipsychotics were introduced, there was a lot of enthusiasm because they did not have this type of a side effect of inducing the drug-induced Parkinsonism. But as the time passed by, we realized that these medicines, although they don't cause the neurologic side effects, the movement disorders, but they are quite notorious in the sense that they are leading to obesity and also to bringing forth, the metabolic syndrome and even diabetes. I had personally the experience that many people, because of the clinical trials, to whom we have been following many patients for years together, and I have personally seen them, transition from being normal people, metabolically normal people, to developing the central obesity, then developing a state of insulin resistance, and then getting into frank diabetes. So yes, second generation antipsychotics. But out of the second generation antipsychotics also, there are a couple of ones, which are relatively neutral about this. For example, aripiprazole is one such antipsychotic, which we can say is useful in this respect. Otherwise, for example, olanzapine, which is a very commonly prescribed second generation antipsychotic, is pretty notorious, about this whole weight gain and the hyperglycemia thing. So we have to be aware that there is a positive side to every medicine, and there could be a flip side to every medicine. And the commonly used antipsychotics nowadays, they do carry this risk for the insulin resistance, metabolic syndrome, and even diabetes. Then a second set of older medicines. We all know that in olden times, tricyclic antidepressants, imipramine, amitriptyline, I think we still use. We use it for neuropathy and sleep disorder now more commonly than as an antidepressant. But tricyclics as a group, they also influence the glycemic status in an adverse way. So we have therefore to be mindful, when using these medicines, that one is that people need to possibly have the lifestyle interventions really in place. They need to be mindful. The physician or the psychiatrist need to be mindful about the weight gain part. We should periodically assess, that the patient's glycemic status is normal. And then we are happy about it. Otherwise, tricyclic and second generation antipsychotic, just to remember the headline, so to speak. But of course, smaller doses we can use safely. It's not to say that, because sometimes this phenomena we also know is dose dependent also. So if we are using small doses, 10 milligram, pretty safe, in terms of the sleep inducing property as well as its utility for neuropathic pain. Pretty safe, small doses. Same way, smaller doses of antipsychotics, sometimes they are used as add-on in medicine also, to deal with the depressive disorders, so on and so forth. So they could be fine, but we need to be aware, of these, the diabetogenic effect of these medicines. So that is one set of things. Then coming to the second part of your questions, that are there any medicines which are useful? So if you remember, I had mentioned, that not only the depression and diabetes or the spectrum of psychiatric disorder, which includes even psychosis also, as Dr. Aarti mentioned. So psychiatric disorders and depression diabetes, schizophrenia, they all share common genetic sort of a linkage, which implies that people with diabetes, they have a higher prevalence of psychiatric disorders. And that sets in a sort of a vicious cycle. Diabetes, psychiatric disorders, stress, it all sort of plays onto each other. It tries to magnify each other. There is a sort of a multiplicatory effect, if people have the two problems together. And that's why it becomes extremely critical to manage the mental health side of the patient. Because unless the mental health side of the patient is managed, the diabetes control is not adequate. Like we see in many of our common shared patients also, that their glycemic control is not okay. And then we realize that this patient has a lot of stress or a sleep disorder or is suffering from depression or anxiety. And the moment you cover that aspect, you find that there is an improvement in the glycemic status of the patient also. So I guess that it's very critical, for us to really be mindful about this. On one hand, keeping the side effects of the medicine in mind, but on the other hand, keeping the utility of these medicines also in mind. So judicious.
I think that was a great answer, because we most of the times feel that only the psychiatric drugs are the culprit. But I think the benefit of improvement of mental health also goes a long way. So both ways it acts as benefit as well as a side effect profile that we need to remember. So madam, coming back to you, Phadke madam, what is the role of HRV in identifying the autonomic dysfunction? So is HRV a good marker for allostasis? What is allostasis and how do you really look into this?
Yeah, so Vaishali, to just give you an idea or difference between allostasis, homeostasis and allostatic load, all of you know that maintenance of constant internal environment, we call it as homeostasis, and there is always a fluctuation that occurs around a set point. While whenever we are exposed to any kind of stressful stimulus, these fluctuations, they are of a higher amplitude. And you can say that the expanded kind of homeostatic regulation is what the allostasis is. So allostasis is nothing but the higher fluctuations in the regulation of different function. And whenever we are exposed to this chronic stress for a longer period of time, what you see is that the body never returns to the baseline or the baseline set points, and there are always an accumulation of error which actually results into shifting of the set points around which the body oscillates. So you get a newer set point and this newer set point becomes the norm. So this original set point and the newer set point, the difference between these two is what is the allostatic load. And why we call it as a load? Because the new set point is not a natural set point that is given to the organism. It is something at a higher level, and now on that set point, you have to regulate your homeostasis. So this becomes a load on the system. And autonomic nervous system plays a very important role into it in development of, say, allostatic load, because normally all what we respond to any internal or external stimulus, your autonomic nervous system plays a very important role because it's the fastest connecting link between your mind and body. So along with endocrine system, definitely autonomic is the first system which respond to different kind of stimuli. And whenever there is a malfunction or dysfunction of this response that is generated by autonomic nervous system, maybe if there is, we are born with a heightened kind of sympathetic drive, overdrive. And this sympathetic overdrive itself, it leads to a lot of disease condition, because it creates an allostatic load and leads to different disorders like diabetes, metabolic syndrome, cardiac disorders like that. Or if the autonomic branch of vagus, if it loses its control over sympathetic, because normally sympathetic is kept under check by the vagus. And if the vagal check or the brake is withdrawn or vagal brake is not effective, then the sympathetic system automatically overdrives. And this also lead to the build-up of this allostatic load. And therefore, I think the proper functioning of or balance between the activity of both branches of autonomic is highly crucial for the maintenance of allostasis and homeostasis. And the most important thing is that, yes. And the most important thing is that if this chronic stimulus, it continues over a period of time, then definitely the allostatic load builds up because of the overactivity of sympathetic.
So if I understand rightly, the balance is very important. The balance between the sympathetic and parasympathetic is very important for autonomic health and effectively a good mind health. So this is what you're telling us, and HRV becomes a very good marker to identify what is going on.
To come to the HRV, HRV is a very important, very simple, non-invasive. It's a very simple and non-invasive marker of cardiac autonomic activity, which has a lot of predictive value, which has a lot of prognostic value. We are using it in our clinic, and it's my own experience through which we see that overall, if you find that the HRV is reduced, if it is well below the norms that are there, then it indicates that your disease process is deteriorating. So if we are able to track the individual right from the beginning, if we take the HRV at different point of our times in our clinic, and if we find that there is a decline, progressive decline in the HRV, then it itself can tell you that the disease process, autonomic dysfunction in this patient, maybe the hypertensive, maybe diabetic patient, it is deteriorating, and which has its own effect on the development of complications. So it has a lot of predictive value. It has we are using it as a screening tool for the assessment of complications, for diagnosis of, not for diagnosis, but to screen out the complication of diabetes. And there we see that if the HRV is less than below a specific point, then definitely, as you already know that there is a lot of problems that you get because of cardiac autonomic neuropathy in diabetic, and especially silent ischemia is very common. So patient will not give you the symptoms of ischemia, but if you check their HRV, you will definitely find that if the person is having CAD or the coronary atherosclerosis, which is blocking the artery, then the HRV of these patients is reduced very, very low, and that itself is an indicator that this subject should be sent for the cardiovascular evaluation.
So HRV is an important marker, and we should be looking ahead into this. So Dr. Aarti, how do you really suspect that the patient has a psychiatric problem or needs a referral to the psychiatrist? So are there some markers? We have a mixed audience with us. So if you can give some important take home in terms of who should be referred to psychiatrist, and what are the markers to identify?
See, identification of psychiatric patients, I'll point out two main factors here, especially for people who have busy practices. One is that physicians themselves have a lot of hesitancy in asking about emotional status. We've not been trained like that in our MBBS days, to ask for emotional status of a person. Or sometimes I think, what if I ask, am I acting too personal to ask this question? Or if I ask this question, will I get a long response and there's a huge crowd waiting outside? So busy OPD is another thing, which prevents a clinician from asking about emotional status of a patient. But like I said, many a times we think that we are hesitating to ask, that the patient is not going to answer us. For all you know that the patient is wanting someone to ask you a question about his emotional health, to come out with it. So it gets very easy for them to actually interact with a person like a physician whom the patient has been going to for years together to see his diabetic status. It may be actually difficult for this person to come and speak to me as a psychiatrist the first time, it will be difficult for him. So just like, asking them open-ended, like I said, questions like, how is your emotional health, or how are you feeling? How's your mood? Do you feel low, depressed? Do you have, enough of enthusiasm, enough of interest to do things? These are very, very simple questions that a person can ask. Now, a person may just break down in front of you in the OPD sometimes when you ask these questions. And these are, again, uncomfortable things that a clinician usually comes across. Let them take their time. Okay, you don't have to keep digging in or keep consoling the person all the time. Just let them know that, okay, I understand, you're feeling overwhelmed. If you wish to speak about it at a later date, I'm fine with it. Or, let's talk about it some other day. Or just go to a neutral topic like, have you had your breakfast today? Or, how did you come today? Did you come along with someone today? And then, then you can go along with the flow of the conversation. When you come to know that the patient is actually depressed, like I said, the other pointer that we have to be careful about is death wish or suicidal wish in a patient. So if the patient is expressing suicidal ideas, I think it's better to start the patient on an antidepressant. And if you feel that, okay, you're apt enough, you can start. If you don't feel, confident enough, then better refer to a psychiatrist. Also ask about the sleep appetite pattern of a patient. So if you think that the sleep appetite is really being disturbed, obviously the patient is not emotionally doing well. I think that itself, requires a referral to the psychiatrist. Sometimes, just educating them about small things about diabetes goes a long way. Providing them education about, how to deal with their daily tasks, about dealing with how to carry their insulin, how to give themselves that insulin injection in a crowd or in a huge office complex where, a lot of people see them or look at them. These small things, I think each time if a patient is educated on a regular basis, I think their distress associated or their depression associated with the illness itself starts coming down. They start feeling more in control of the situation rather than, feeling overwhelmed by the situation itself.
So you touched on two important points that these techniques can help us to prevent diabetes distress as well as the burnout that is very common in diabetic patients. So, sir, we have last few minutes to discuss on how a diabetic patient should take care of his mind, because we've seen that it's been affecting the mind significantly. So what mind-body interventions would you advise, and what would you give a take-home in terms of World Diabetes Day as a theme that educate to protect tomorrow? So what should be they doing?
Absolutely. I think it's a wonderful theme that they have this time because that is the real key for better outcomes, better quality of life for these patients. And let me say that, that by now, through our discussion within this panel, the audience perhaps got the gist that we no longer are operating in silos, mind separate and body separate. Dr. Leena, in a very elaborate way, explained that how the mind and body, in a way, are very intimately connected. So let us, instead of putting it in silos, the mind care versus the body care, let me put it this way, that in order for us to understand and keep in mind some very simple, pillars of health. We know that a strong edifice stands on good, strong pillars, so our health also stands on good, strong pillars. And much of the research, biomedical research in the last 2 decades has told us that it finally boils down to one first pillar, I would say, the good sleep, very important from the viewpoint of overall management of health. So one has to be, the physician has to be mindful, treating physician, as well as the patient, that the sleep is good. 6 to 8 hours of daily sleep, refreshing sleep, that is what we are looking at. Second very important aspect is the nutrition, digestive health and a nutrition. That has to be something which again should be the important point for educating the patient. Physician has to be aware, patient has to be aware. Third very important aspect, of course, is one of maintaining the fitness. We know that there is a overall now global consensus, about 150 minutes of moderate physical activity per week, which boils down to simply just about 20-25 minutes per day. Very easily doable, practically there is nobody who can claim to be so busy that they can't invest 20 or 25 minutes of their, and it is equally good, for mind health also the physical activity is equally good. Physical health, mind health for both. So good fitness and exercise, good nutrition, digestive health, good sleep. And fourth, perhaps, equally important, now we know from the positive psychology studies, is about the mind health itself. being sort of aware, reflecting on one's own psychological experience, ensuring that one by and large is in a sort of a pleasant state. We know that happiness, sadness, anxiety, anger, all these emotions are common and they are part and parcel of life. So we are not looking out, to be happy every moment of our life, but we generally want to feel pleasant. And that very often, as we know, it happens when our relationships are good. Sexual health, of course, is an important aspect of that relationship, not to miss out on that. And most importantly, our engagement with daily life. Sometimes we try to look at some very esoteric kind of solutions in order to feel pleasant. But it is our good engagement with meaningful activities in our daily life, in our relationships, which enriches our life. So I would say that these are four, we have to remember: good sleep, good fitness, good nutrition, and good pleasant feeling, good mind health, if you want to use that word. So these simple four things, I would say is something for the patients to remember and for the physicians to remember. So the two of them, they have a dialogue, they have a shared decision making, they agree upon, that these as the common health giving goals. And that is perhaps is the essence, of this year's Diabetic Day message, that this is what we need to constantly keep each other, making aware about. That in addition to all our other pharmacotherapeutic interventions and all our other routine of investigations and monitoring the overall health of the patient, we shouldn't miss out on these fundamental pillars of health. So that is what I like to sort of add from my side. Thank you.
I think that's a wonderful answer, sir. I think the whole panel has discussed the importance of taking mind health as an integrated part of body health. So it is not body separate, mind separate, and it's everything put together as a teamwork. So we have team of people involved, and we saw the flow of the whole session, right from brain as a causative effect to the mind being affected, and how mind care is as important as the physical health care. So I think this whole discussion has been very elaborate. It's very apt on the eve of World Diabetes Day. And I thank all of you. You all are busy people, but you all have taken nice 40 minutes off for this discussion. And it's been an excellent listening to all of you. And I'm sure the audience is going to benefit from this. And we are going to talk more on mind health day by day, because we are expecting a better outcome as a result of this mind health improvements.
The most important, what I mentioned about the effect of ANS on mind health. So in connection to that, very important link now that has been found between between ANS and different functioning is the gut-brain axis. Gut-brain axis via ANS. It has a lot of influence on functioning of mind. So it is mediated through ANS. So that is one important link. And the second, pertaining to the role of ANS in diabetes, is the effect of vagal stimulation on the anti-inflammatory kind of role of vagal stimulation, because vagal stimulation itself shows a lot of effect on reducing inflammation, which is very, very important pertaining
role
to
in
the
immunity
diabetes
and microbial endocrinology.
Yes, yes.
Both.
So the immunoautonomics and neurocardiology and the gut-brain axis, where the ANS plays a huge role in giving information to the mind and affecting and influencing the mind.
So we say that microbial endocrinology affects behavioral endocrinology. So
absolutely.
I think that's true about the nervous system.
And that is mediated through ANS. So ANS plays very important role in it. And
so
afferent
we will have neurologists treating diabetes. So I think we will have autonomic regulators treating diabetes.
Yes,
so,
yes.
Yeah, so I think that was wonderful. Thank you all for being here. And it was nice interacting with all of you. Thank you so much.
Thank you.
Thank you.
Okay,
Thank you so
bye-bye.
much.
Yeah,
Bye.
thank you.
Thank you so much, Dr. Harish, Dr. Rahul, Dr. Leena, Dr. Aarti, Dr. Sanjay, and Dr. Vaishali for your time and efforts you took to share your thoughts and experience with DocPlexus community. A big thank you to all our dear audience for their kind listening. Stay tuned for our upcoming session on Global Experts Roundup on Diabetes Management tomorrow at 3 p.m. Until then, take care and happy DocPlexing.